but you can hear us, no?
Yeah. Yeah, you can start, I suppose.
Okay. Good morning. Today we'll have a short case discussion on cervical lymphadenitis. We have put the term as lymphadenitis because we'll like to discuss more on the infective cervical lymphadenopathy because we'll have a separate session for lymphomas. But again, DD will come to that. With us today will be Dr. Behrul Huda, who is a second-year DNB resident at Southeastern Railway Hospital, and today our teacher will be Dr. Sudip Shah, who is a professor and head of surgery at NRS Medical College. So, Behrul, you can share your screen and start presenting.
Yes, sir. Am I audible, sir?
Yes, please start.
Good morning, sir. Myself, Dr. Behrul Huda, surgical resident from Central Hospital, Southeastern Railway. My case is a case of cervical lymphadenitis. So, a 25-year-old female named Deepika Anna Lagra, by occupation technician, resident of Kharagpur, presented with chief complaint of swelling in the left side of the neck since last 1 month, fever for last 2 months. History of present illness. The patient was apparently well 2 months ago when she noticed a swelling in the left side of neck, which was insidious in onset, initially smaller in size, approx 1 centimeter into 1 centimeter size when noticed by the patient herself, gradually increasing to the size of 2 centimeter to 3 centimeter over a period of last 1 month. The swelling was not associated with pain. There were no any other swelling in other parts of the body. Fever for last 2 months, which was intermittent in nature, low grade, and fever usually comes in the evening, associated with excessive sweating in the night. There was no chills and rigor, not associated with joint pain or rash. Patient has got no history of pain, fever preceding the swelling, ear pain, running nose, bleeding through nostril, no history of hoarseness of voice, dyspnea, dysphagia, no history of any abdominal pain, swelling, hematemesis, melena, or alteration of bowel habits, no history of lawn pain, hematuria, urinary difficulty. There is no history of loss of consciousness, convulsion, or headache. There is no history of weakness of limbs. Past history. Patient has a past history of intermittent fever, cough, and generalized weakness in the month of August 2022 associated with weight loss. For the above complaint, patient was evaluated and diagnosed as a case of pulmonary TB. So, and later he completed her antitubercular drugs in February 2023. After that, patient was well. There is no history of diabetes mellitus, hypertension, thyroid disorder, or any other illness. There is no significant past surgical history. Family history: both parents are alive and healthy. There is a history of tuberculosis present in grandfather. Personal and social history: she's married, has bearing 1 child. Both child and spouse are healthy. Bladder, bowel, sleep are within normal limit. Appetite is reduced. She takes mixed Indian non-veg diet. There is no addiction present. Belongs to average income socioeconomic class. Menstrual and obstructive history. She attained age of menarche at the age of 13 years. Menstrual cycle is regular. Duration is 3 to 5 days. Last menstrual period was 6th of July 2023. Parity is 1+0. Physical examination and general survey. I have examined the patient.
Before you go to the examination, can we have a look at the history?
Yes, sir.
The first
Yes,
slide,
sir.
please.
Yes, sir.
Yes.
Next.
Yes, sir. Chief complaints.
Yeah. Swelling in the left side, but 1 month.
Yes, sir.
For last 2 months.
Yes, sir.
Yes, next one.
So fever should be first. You see, if you go by chronology, if a patient is having fever for 2 months, then we better put the fever as 2 months and then go to the fever history and then come to the swelling. That is
Yes.
what you do in MBBS level, but in PG level, it's okay, fine. But
Yes, sir.
Yeah, next. So the chief complaints, there is no pain.
No, sir, no pain,
Fine. Next.
sir. History of present illness, sir.
And later you had said that she had completed her anti-cox treatment in the month of February.
Yes, sir, February 2023, sir.
Yeah, so that means in the last 4 or 5 months she was fine.
Yes,
And
sir.
things started happening only 2 months back.
Yes,
That's
sir.
right?
Yes,
Okay,
sir.
fine. Yes.
but then I will not agree to this line that patient was apparently well 2 months ago. This is a small gap of 6 months. I would prefer that you start the history with the history of pulmonary tuberculosis. Patient is a known case of pulmonary tuberculosis who was treated from this period to this period. She was
Yes, sir.
well for 4 months following the completion of treatment, and then subsequently noticed this. Dr. Shah, what do you think?
Yeah, exactly. Because since you have already told us that she already had ATD treatment, that means you must be knowing things, and even she knows, even the patient knows that she had it.
Yeah.
And tuberculosis is such a common thing that
Yes, sir.
even who is completely illiterate, he or she
Yes.
will also tell you that yes, I have had tuberculosis in the past.
Yes,
No,
sir.
she's
Yes.
a quite literate lady, technician in railway hospital, railway
Yeah,
department.
Yes, sir.
So I think better there is a gap of 5 years or 2 years is fine that you take this to the past history. But patient having a small gap of 4, 5, 6 months, you can start with the beginning. Then it become more clear about the history.
yeah, it is more pointed.
Yes, sir. Yes, sir.
Okay. What is the characteristic of this fever?
Sir, the
Because
fever
a
was.
patient may have it. Keep in mind that all
Yes, sir.
TB patient not necessarily will be a TB. We find a lot of situations that patient was treated TB, but patient has got lymphoma. So
Yes,
you
sir.
have to keep in mind that this may not be tuberculosis because she is treated for tuberculosis. 4 months down the line, she is developing a swelling. So you
Yes,
should
sir.
always consider other possibilities. So as we go to the history of fever, what do you
Yes, sir.
find history of fever is typical about?
Sir, she was having a low-grade fever, and she complaints of fever usually comes in the evening, and with associated with sweating in the night. And there was no high-grade fever in this patient, and there was no associated chills or rigor.
Okay. What is the characteristic of fever in patient having a lymphoma?
Sir, in patients of lymphoma, the fever usually comes for 7 to 10 days, and after that there is a
There is a gap.
free of gap of 7 to 14 free of pyrexia for a gap of 7 to 14 days in case of lymphoma patients.
Okay. I think he has more or less covered.
Yeah. Otherwise, he has taken the history. Then, as you mentioned about the other part, go to the next part.
Yes, sir.
What in the head neck is important, the history? You have mentioned about the hoarseness of voice, dyspnea, ear pain. If it is just a chronic lymphadenitis, what specifically thing you ask for?
Sir, if it is a case of chronic lymphadenitis due to infection like throat infection, is there any previous history of throat infection or present or not? That in that case, the patient would complain of hotness of voice or dyspnea or difficulty.
Hoarseness of voice is something which might be a metastatic disease. Okay.
And is a very late feature.
Yeah.
Yes, sir.
Anything else? The patient may have some infected, some lesion in the scalp or any history of abscess in this region.
Catchment area.
Yes, sir. Drainage. Yes.
Why do you ask about history of loin pain, hematuria in this patient who has got a cervical lymphadenopathy?
Sir, in cases of malignancies, the lymph nodes may present at cervical region in case of urinary bladder malignancy in advanced cases.
A bit far-fetched. Before that, you will have certain other problems because you see, urinary level malignancies, they usually have hematogenous spread.
Yes, sir.
Right?
Yes,
Okay,
sir.
proceed.
Yes, sir.
Yeah, so from the family history point of view, the patient is absolutely clear. There's no family history of tuberculosis.
No, sir, there was a history of tuberculosis present in the grandfather.
Is he alive?
Yes, sir, alive, sir.
Okay. Okay, fine.
Yes, sir. So should I start with physical examination?
Yes, sure.
I have examined the patient in well-lit room after taking a proper consent in presence of a female attendant. The patient at the time of examination was alert, conscious, cooperative, and oriented to time, place, and person. With an ECOG score of 1, decorative of choice was present. Facials normal, gait normal, average build. Weight 155. Height was 155 centimeter. Weight was 50 kg with BMI of 20.8 kg per meter square. Hydration was adequate. Nutrition average. There was no pallor, cyanosis, clubbing, jaundice, or edema. Having a pulse rate of 90 per minute. BP 110 by 76 millimeter of mercury. Respiratory rate 16 per minute. Temperature was normal. There was no engorged neck veins, no any obvious deformity, no pigmentation. On local examination, on inspection, 2 centimeter into 3 centimeter swelling in the left side of the neck, mainly in the supraclavicular region, which was ovoid in shape, smooth surface, well-defined margin. Normal. There was a normal skin over the swelling. There is no any other swelling present. There is no visible scars or sinuses present. On palpation, inspective findings were confirmed on palpation. Temperature was normal. There was no tenderness. Swelling was ovoid in shape, smooth surface. Margins were regular, firm in consistency, freely mobile, not fixed to underlying structures or skin. Skin over the swelling was normal. There was no palpable pulsations. There was no fluctuation, and the trachea was in the midline, and thyroid gland was not palpable. After that, I have examined the examination of the drainage sites were done. Both scalp head was normal. Oral cavity, tongue, buccal mucosa, Walden's ring was also examined, which was normal. Nasopharynx, tonsil, nasal cavity, paranoid sinus, thyroid gland, and other lymph nodes revealed no any abnormality. After that, systemic examination have been done, in which respiratory all the systemic examinations were within normal limit. Case summary: a 25-year-old female presented with complaint of swelling in the left side of the neck for the last 1 month. Initially, she noticed a swelling in the left supraclavicular region, which was initially small, reaching to the size of 2 centimeter into 3 centimeter at present. Associated with fever since last 2 months and loss of appetite also. Patient has a history of pulmonary tuberculosis in August 2022, for which she completed ATD treatment in February 2023. On examination, 2 centimeter into 3 centimeter palpable lymph node in the left side of the neck in the supraclavicular region. The lymph node is non-tender, firm in consistency, smooth surface, not fixed to the underlying structure or skin, and with normal systemic examination. Provisional diagnosis. This is a case of tubercular cervical lymphadenitis.
Okay, let's go to the first slide of examination.
Yes, sir. Yes, sir.
Okay. So this is basically the general examination or general survey that you say.
Yes,
Yes,
sir.
you have done the general survey. Yes, next. Okay.
You see, in general survey, you need not mention about making a heading of weight, height. You just say BMI. That covers.
Okay.
Understand? In the
Yes,
heading, you need not write. And when you present in the exam,
yes, sir.
if everything is normal, you can just pass over online. General survey is essentially normal. That's it. Otherwise, you spend time on this presentation.
Yes, sir.
But the exam will be a limited time exam, na? So you have to be very brief.
Yes, sir.
Very. And another point is there, because if you go through the general survey very quickly, saying that it's essentially normal, in that case you can save time to answer certain other questions which are more relevant to your topic.
Yes, sir.
Right? Yes. So
Now it's a time-bound exam.
in a postgraduate exam, this is very much expected, and we expect students to come out in such a manner that you can go away with normal things and only highlight certain things which are very important. In undergraduate exams, yes, you have to tell us in detail that what we have seen, starting from pallor, jaundice, and things like that. Okay,
Yes.
next slide. Yeah, next. Inspection. Yeah, local examination. Now you see, as far as lymph nodes are concerned, I think now it has been decided that whenever
Yes,
you talk about lymph node, we will use only one dimension and the maximum dimension. You don't need to mention 2 centimeters into 3 centimeters swelling. Right?
Yes, sir.
You can mention one maximum dimension, that is sufficient. Okay.
Yes, sir.
And yes, Mahmoud.
And PG level, I would expect that you start with the statement that one of the supercardiac lymph nodes using the level 5 is this is the lymph
Yes,
node.
sir.
Okay, because
Yes, sir.
you see, you have surgically you have defined levels of nodes, and it's
Yes.
wise to start with the level so that examiner knows, yes, he knows the level of lymph nodes. So
Yes.
I think once you say supercardiac falls in which group?
Sir, level 5 blue volume nodes.
Where does the varicose node falls? Which group?
Sir,
Remember
level 4.
varicose,
Level
Level
4.
level 4. Yes.
yes,
Yes.
you're correct. And remember, varicose is actually the medial supraclavicular group. It
Yes,
is where do we find it? Where do we palpate for varicose?
Sir, between the two heads of the sternocleidomastoid muscle.
Yeah.
Exactly. Yes, that's correct. So apart from the medial group of because supraclavicular has basically 3 groups: medial, intermediate, and lateral.
Yes, sir.
The other 2 will fall in level 5, and the
Yeah.
medial one falls in level 4.
Yes.
Okay.
Yes.
Okay. Pass on to palpation. You said it's a firm node, and then you started doing a fluctuation test. Why? Next slide. Next slide.
Yes.
It's firm in consistency.
Yes, sir.
So why do you try to elicit fluctuation in a firm swelling?
Sir, trying to see that if there is a central necrosis present or
You
not.
see, you cannot contradict your finding. It's not to be done. Fluctuation is done to assess a cystic swelling.
Yes, sir.
Okay. For a
Yes.
firm swelling, you need not do that. You see, every point is not required. You are not trying to do a compressibility test in a swelling like this, which is firm in consistency. Okay.
Yes, sir.
Now, where has he mentioned fluctuation test?
Next.
Oh, the next slide. Okay.
No fluctuation.
Yeah. No fluctuation, he said.
No fluctuation, no pulsation. Trachea in the midline, thyroid gland not palpable. Okay.
You said it's not fixed to the underlying structures.
Yes, sir.
What you have tried to elicit? What is the structure underneath?
Sir, if in case of malignancy, it will fix to underlying structure or bone, or in case of muscle.
How have you tested for that? If you say supraclavicular node,
Yes, sir.
and you're trying to say that swelling is not underlying structures, what structures are there underneath?
Yes, also.
What you see? This is a flora posterior triangle.
It's a posterior
Yes.
triangle.
Yes, sir. Yes, sir. Yes.
Is found by the ligatus scapulae and the scalenus medius muscle.
Yes, sir. Yes, sir.
So how do you test for that? How do you now say that yes, swelling is not skin? I understand. You pinch up the skin and say it's not fixed to the skin.
Yes, sir.
How do you assess the swelling is not fixed to the muscle underneath or to the what are the vertebra behind? Cervical vertebra.
Cervical
Or
vertebra.
vertebral fascia.
Yes, sir.
How do you say? What you have
Sir,
done to say this?
Sir, I'll tell the patient that I'll tell the patient on the side of the swelling, just press on the hand so that
No. If you are trying to elicit relation to the muscle, you must move the swelling muscle being. You move the swelling. Okay? Swelling is fixed as such. What is your interpretation? No maneuver, no muscle being contracted. Swelling is fixed as such. What is your interpretation?
it's fixed to underlying structure then, sir.
What underlying structure? Muscle?
No,
What?
to the fascia.
fascia or cervical vertebral
Yes, sir. Or
structure.
cervical.
So if
Yes.
the swelling is fixed as such, this is a general term for any swelling where you are trying to do the muscle relationship. So if the swelling is fixed as such with the muscle being contracted,
Yes, sir.
is fixed to the underlying prevertebral fascia or the bone.
Yes, sir.
Now then swelling is mobile now.
Yes.
So this thing is out. If swelling is mobile, relaxed state, the
Yes,
swelling
sir.
is not fixed to the underlying structure like prevertebral fascia and the bone. Now you try to contract the muscle. If you find the swelling in relation to the sternocleidomastoid or to the trapezius, how to
Yes.
make the patient trapezius taut?
Sir, I'll place a hand over the shoulder and try to just move the shoulder up. I'll press. I'll tell the patient to
He
move.
will move his shoulder up against resistance.
Yes, sir. Movement of the shoulder against resistance.
And then you test it. Okay.
Yes.
So that is how you do the testing. That should be clear. This is a situation for suppose breast again, pectoral fixity. You do the test with the pectoral being relaxed
Yes, sir.
to exclude is not fixed to the chest wall. Okay.
Yes.
These are, you see, some examiners are very fussy about the clinical part. So if you are not well in the clinical part, he may not take it to the next step. DNB is a very tricky exam. Some examiners are very persistent about a particular thing.
Yes, sir.
Okay. Yes, Dr. Shah.
Yes. Now these lymph nodes, where are they situated? By situated, I mean you have said it's a posterior triangle. Fine. Now,
Yes, sir.
in the posterior triangle, there is a fascia, isn't it? What is that called?
What is the fascia in the neck?
Deep cervical fascia and
Yes, there is a deep cervical fascia.
yes,
In this fascia encloses the sternomastoid, and then at the posterior border, it becomes the single layer. It travels across the triangle and then again splits to enclose the
subclavius.
trapezius.
Which layer fascia is this? Which layer fascia is this?
Yes, sir.
Which layer is this of the deep cervical fascia? As Dr. Shah has described, split to enclose the sternocleidomastoid, go on the floor of triangle, and then split to enclose the trapezius. What layer it is?
Investing layer.
Investing layer, yes.
Yes.
Yes, exactly. With relation to the investing layer, I would like to know where are the lymph nodes?
Sir, these lymph nodes are deep to the fascia, deep to the investing layer.
Investing layer of fascia, exactly. Yes. So now Mahunda was telling us about some muscles
Yes, sir.
which form the floor of the posterior triangle. Can you just name them? I mean, in case I think it's very much anatomical, but still, I mean, mentioned in the books very clearly. There are approximately 4 muscles to start with.
Scalenus, trapezius.
You just can't say the trapezius forms the posterior
No,
boundary.
doesn't floor. It's from the boundary.
Yes.
Basically, semispinal is from the top. Yes.
Yes,
Then is capitis, levator scapulae, and lastly the middle scalene muscles.
Yeah. Scalenus
Yes.
medius.
Yes,
Yes.
sir.
Scalenus anterior is hidden by the sternocleidomastoid.
Yes.
Now this is called the posterior triangle. The posterior triangle is divided into 2 parts.
Sir,
Level 5 is divided to level 5 is 5A and 5B nodes. Or in relation to what?
it is divided on the basis of posterior belly of digastric muscle.
No. Posterior leg is a carpenter side. Doesn't come in the posterior triangle at all.
Digastric is way up. Digastric is
This is based on spinal accessory nerve.
Yes,
As you
sir.
see, the posterior triangle, the spinal accessory nerve goes down
Yes,
to the trapezius. So nodes above and below
yes.
the accessory nerve.
So in the posterior triangle, the spinal accessory enters. Where does the spinal accessory enter the posterior triangle? Can you tell us?
Sir?
It is named by a point.
If you take the surface marking, where would you find the spinal? Because in neck dissection, you need to find this landmark. In the posterior triangle, where do you search for the spinal accessory nerve?
Now listen, one thing you have to accept, in a neck swelling, you will be, anatomy is going to play a very important role, right?
Yes, sir.
So yes, we'll give you the answers. The spinal accessory comes out somewhere in the middle or between the upper third and middle third of the sternomastoid, right? And this has a name. It has a name. It is called the Erb's point. Why is it called the Erb's point? Any idea?
Is the nerve lying singly or some other nerve is around this?
Some other nerve is around this, sir.
Which nerve?
Not other,
So
there
it
are
goes to
many
the
other.
angle of mandible.
Greater ocular nerve.
No. It's what?
Now, local
It's a great.
anesthesia in this region, if you administer local anesthesia in this region, right,
Yes, sir. Yes.
you can perform any kind of, I mean, say you can also perform an hemithyroidectomy if it is done bilaterally, right? Because there are a number of cutaneous nerves which come out from this point, right? As
Yes.
you said, one was the great auricular, and one
Yes.
is this nerve which we are talking of. There are superior cervical nerves, right?
Yes.
So many nerves come out, and all these nerves can be anesthetized just by injecting local anesthesia in this region. And as I said, if you do it bilaterally, you can also perform a hemithyroidectomy by this procedure. Anyway, let's move on. Okay.
Yeah.
Yes.
So you have examined all the sites, right?
Yes.
As
Yes.
you have mentioned in this drainage site, the catchment area.
Yes, sir.
Okay. Now you see, nasopharynx. I mean, you can't examine the nasopharynx just like that. You will need some equipment to do that, right?
Yes.
And the same thing is nasal cavity, paranasal sinus, and these areas. When you want to examine, you will
You
need
need ENT help. You need ENT help.
Yes, sir.
So let's come down to your summary.
Yes.
Make a habit of making 2 paragraphs. One paragraph is the history, and second paragraph will be your examination. So on examination, general survey is essentially normal. On examination of the neck, this is the finding, and system examination is normal. So that is a better way of presenting. Okay.
Okay, sir.
Yeah, next slide, the second part. Okay, fine. Now just see in this summary, if I remove, just for example, if I remove the history of tuberculosis,
Yes, sir.
then what would have been your provisional diagnosis?
Sir, then I'll go with both tubercular lymphadenitis and lymphoma.
And
And
lymphoma. Yes, that's right. Lymphoma.
only two, but I have a lot of other diagnoses.
Yes.
Sir, it can be also due to chronic.
Then you first justify why do you say this tuberculosis? As Dr. Shah said, yes, if you take the history of pulmonary tuberculosis, and what are your points in this patient to say it's tubercular?
Because in this patient, the fever is usually low grade, comes in the evening, and it is in this tuberculosis patient, it has not got a pyrexia free period. That is, in lymphoma, you usually get a period of apyrexia between 7 to 14 days, in which these patients have.
It's not. Don't confuse. Pale abstinent type of fever is not found in 100% patient of lymphoma.
Yes,
that
sir.
you find in 30 to 40% patient. So that is not typical and essential part of diagnosis of lymphoma. So in this patient, tuberculosis because of what? One is fever. What else?
One is fever. Other one is the palpatory findings. That is the lymph node was.
Before that, you already mentioned patient has loss of weight, some amount of loss of appetite. So patient has some general symptoms. Patient
Yes,
has
sir.
night sweats, and
Yes, sir.
then past history of tuberculosis for which you was treated for about 6 or 9 months. So these
Yes,
are
sir.
points from the history.
Yes, sir.
On examination, can you justify what is tubercular?
Sir, the lymph nodes were firm in consistency, and they
That's
were.
it.
Yes, sir.
You see, this is overlapping now. There is no clear finding on examination to say tubercular node, because tubercular node may be variegated field, maybe
Yes, sir.
fluctuant. Okay.
Matted also.
So
Yes, sir.
there may be a discharging sinus. So these are all typical of tuberculosis.
Yes, sir.
Second, you say is lymphoma. Why? Second is lymphoma.
Sir, this cannot be lymphoma because this
You
patient
cannot make a blank statement. It cannot be lymphoma. You cannot say like that. You have considered the possibility lymphoma as a second possibility.
Yes, sir. It can be also, sir. But for
Yes, you're perfectly right. It can be a lymphoma. But the thing is, in a lymphoma, yes, it is possible that you can have only a single lymph node. But usually, when lymphoma patients come to us, they
With
usually
multiple
come
lymph
to
nodes, multiple enlarged lymph nodes.
It's possible, but very unusual to get only a single lymph node in only one particular group or one particular level of the neck, right? That is one
Yes,
thing.
sir.
And
Yes,
the
sir.
consistency in case of lymphoma,
It's a rubbery in consistency.
it is rubbery in consistency. And remember, lymphomas also have some constitutional symptoms, as in case of tuberculosis.
Sir,
Right?
yes, sir. Yes, sir. Yes, sir. These people have
What-
got.
Pruritus,
These people.
pruritus, sweating. Okay.
Yes, sir.
Fever. They're all the other symptoms of lymphoma. But I think you should always keep the possibilities of chronic
Lymphadenitis, chronic pyogenic
lymphadenitis
lymphadenitis.
because of some bacterial infection. Because you see, you have said there is no pharyngitis, no other features, but their
Yes.
patient may have some infection in this region and cause a chronic lymphadenitis. And another entity is viral infections.
Yes, Epstein-Barr virus.
Okay. So
Yes.
some viral infection can cause chronic lymphadenitis, although there are some viral infection which may cause even generalized lymphadenopathy. So even for generalized lymphadenopathy also, you should keep in the possibility of a viral infection.
Yes, sir.
Now, can a viral infection cause malignancy?
Yes, sir. Epstein-Barr virus is associated with malignancy.
I think you should tell the commoner one first, right? It is actually
Yeah.
the other way around. It is the malignancy is actually due to the virus to start with, and that
Yes,
is human papilloma virus.
Yes, HPV also. Yes, sir.
Epstein-Barr virus, yes, you're correct, but that frequency is much less.
Yes.
And nowadays, in the Western countries, most of the malignancies in the head neck are due to human papilloma virus.
Yes.
They have outshone the malignancies due to non-human papilloma virus. That is because if you see the latest IJCC classification,
Yes,
they
sir.
have divided the two things, right? One is HPV positive malignancy and one is HPV negative malignancy. But in our country, still HPV positive is not that much as is seen in the Western countries, right?
Yes,
Now,
sir.
just to take the discussion further, suppose it is a malignancy.
Yes, sir.
Some malignancy in the head neck, right?
Yes, sir.
So, what will be the nodal status? I mean, since we are limiting ourselves to the neck nodes, I will not ask you about the T stage. Let
Yes,
us
sir.
talk about the nodal status as far as malignancy is concerned.
Yes. In case of malignancy,
First of all, how do you put the diagnosis? In the examination, if I know primary anywhere in the body, but you have a node and Dr. Shah is saying this might be a metastatic node.
yes, sir.
So how do you put the diagnosis first?
Metastatic lymph node of unknown primary.
Yes. Yes. Then, if you go by now end staging, where do you place it?
It's already, sir, and lymph node is positive, so it's N1.
Clinically positive. You are putting a clinical diagnosis.
Yes, sir.
There are
So
some definition for cervical node metastatic disease where you put as N0, N1, N2, N3.
So
what?
Now, what is N0?
Lymph node is not positive for malignancy.
Not palpable. You cannot say that. Not palpable.
Yes, sir, not palpable.
Why does this entity come up? I mean, why do you have something called N0? It indirectly means that there is a T lesion.
Yes, sir.
Right? There is a T lesion, but then you don't find any clinical or radiologically positive lymph nodes. Fine, that is why it's called. Now, what is N1?
Sir, a lymph node is positive for malignancy.
No, you have to specify now. You have to specify. There are some clear criteria to say it's N1. What about the size?
Sorry, sir.
Okay.
So
it's less than
what size is 2
3
centimeters?
3 centimeters.
You've already said that. Yes, so this is going to be N1. right?
Yes,
Yeah.
sir. Yes, sir.
And
N2,
remember, the classification which we are talking about now is
Yes.
is for human papilloma virus negative cancer.
Okay.
There is a separate classification for human papilloma virus positive cancer.
Yes,
Right?
sir.
In that there is only N1, N2, and N3. Right?
Yes,
There
sir.
are no subdivisions. But in this, the one which is negative, human papilloma virus negative, in this there are subdivisions.
Yes, sir.
N2 is what? N2?
N2 has subdivision.
N2 is, it may
More than
be unilateral or bilateral node involvement
yes, sir.
and none greater than 6 centimeter.
So it is 3 to 6.
Yes, sir.
If it is single, it is N2A. If it is multiple, it is N2B. And if it is bilateral, that means contralateral nodes are also positive. In that case, it is N2C. Remember,
Yes.
in the 8th edition, they have added another perspective. What is that?
Extranodal extension.
Sir. Yes.
Extranodal extension, clinical extranodal extension, right? So
Yes.
in N1, N2, all extranodal extensions have to be negative.
Yes, sir.
If there are extranodal extensions, then it becomes irrespective of size. If there are extranodal extensions, it becomes
N2C.
N3B,
N3B.
N3B. Yes.
Yes.
N3A is anything which is, or N3 if you say, it is larger than 6 mm.
Yes, sir.
With extranodal extension, it is N3B, and without extranodal extension, it is N3A.
A.
Right? So this is a very simple classification, very easy to remember. Less than 3, 3 to 6, and 6 plus. So
Yes,
very
sir.
simple as far as nodes are concerned. Right?
Yes.
Side by side, if I can ask you just a simple, just a question, keeping myself to nodal status. The another malignancy which we as general surgeons commonly deal with is thyroid malignancy, right?
Thyroid malignancy. Yes, sir.
Very good. Now, can you tell me what is N classification in thyroid malignancy? I mean,
Sorry,
so
sir.
that you need to remember both.
Probably has not read it today.
Yes.
Yes.
He is ready with the
Yeah.
lymphadenitis.
Now, suppose an examiner asks you in a thyroid case, now what is N2? What is N2 in thyroid malignancy? What would you say? So he must be pulling your leg because in thyroid malignancy there is nothing called N2.
Yes.
Please remember that, right? It is
Yes.
just simple N0 and N1.
Yes, sir.
Okay. If
Avian
there
nodes
are
being palpable.
yes, if there are lymph nodes present, it is N1. Now one
Yes,
is you have N1A and N1B. So from thyroid, which are the levels where the lymph nodes will usually be involved? Which level lymph nodes you expect to find in case of thyroid malignancy?
First equivalent node.
Yes, sir. Sorry, sir.
First equivalent node where the thyroid malignancy goes. First.
Sir, level 2 and level 3.
No.
It is
Bhai, you are doing
thyroid का
central
कोई
node
आते हैं।
dissection. Huh? Central node dissection is a part of even a prophylactic thyroid malignancy dissection. So it's level 6 only. First is level 6. Yes, I agree that it will go to 2, 3, 4 and may
Yes.
go to 5. And 1 is usually not involved.
Yes.
Level 1 is not usually involved in thyroid malignancy.
Yes.
So that is why it is very easy to remember. You see, N1A is where the lymph nodes are more likely to go, more likely to get involved. That is level 6 and 7.
Yes, sir.
Okay. So
Yes,
it is more or less a rhomboid area. Okay, starting from the
Sure.
hyoid bone,
Yes, sir.
right? From the hyoid bone and coming down up to the, as I
The-
said, 7. That is up to the innominate artery,
Yes,
the
sir.
upper quarter of innominate artery. This is the lower level of level 7. So 6
sir.
and 7 nodes are involved. It is 1A.
Yes, sir.
Any other level other than these levels, that means 1 to 5, right? If thyroid malignancy lymph nodes are involved in any level 1 to 5, it becomes a poorer stage. That is 1B. Okay,
Yes,
so
sir.
side by side, these two you will have to remember. One is for head neck cancers.
Yes, sir.
The other one we just now mentioned is for thyroid malignancy. Okay. Now,
Okay,
since
we can
there-
pass on to the TB management. So you have this lymph node given a clinical diagnosis. What
Yes,
is
sir.
the next step? What is the next step?
Sir, I'll do an ultrasonogram of the swelling and CBC, chest X-ray, and
Don't say of the swelling. If you say ultrasound, you say ultrasound of the neck.
ultrasound of the neck. Ultrasound of the neck. Yes, sir.
Because other lymph nodes may not be palpable. So you find whether the other nodes are there or not. You very clinical diagnosis. So it's a of the swelling itself. Ultrasound of the neck itself.
Yes, sir. Ultrasound of the neck itself, and a complete blood count with ESR measurement, chest X-ray to exclude pulmonary tuberculosis.
Not
And-
exclude here. To find
Yes,
Find-
or recurrence of
active focus or there is a recrudescence of the pulmonary tuberculosis.
yes, sir, recurrence of tuberculosis, and FNAC of the lymph node swelling.
Suppose I said that this patient has got, I forgot about the past tuberculosis. If there is strong suspicion of lymphoproliferation disorder,
Yes, sir.
what will prefer? Do a FNA or do a straight away excision biopsy?
So in that case,
I'm saying
go-
my strong suspicion of lymphoma in this patient.
yes, sir. In that case, I'll go with the excision biopsy, sir,
Why?
because in FNAC we'll get a simple simple like atypical cells were present in FNAC, but in case of excisional biopsy, we can characterize the malignancy by doing an IHC study also.
Yes.
And
So
yes,
if you have strong, you say tubercular lymph node, FNA is fine. You can diagnose tuberculosis. You can do all other tests to this even a FNA specimen. But lymphoma, you have to typify the lymphoma. You have to
Yes.
make a classification of the lymphoma, and for that you need the excision of the whole node.
yes, sir.
Now, Mahmud, I think even in case of tuberculosis, it is in most cases you will find it's very difficult to diagnose tuberculosis with an FNA because
But
until and
now sensitivity is not bad. If you have strong suspicion of tuberculosis, you can go for a FNA first, and then if not conclusive, you can definitely go for. But in tuberculosis, most of the time, patient has these typical features, and then FNA may help. Yes, I agree. In all cases, in FNA, you may not find the typical finding of tuberculosis.
FNA, you will have to demonstrate acid-fast bacilli. Nothing else in the FNA will tell you that it's tuberculosis. That is a big problem there.
Yeah.
Okay. Now, how do you confirm? As you said, we'll do a biopsy, yes, and FNA followed by, if necessary, an excision biopsy. Fine.
Yes, sir.
Okay. Now, what do you expect to find in case of in the histology?
So in case of lymphoma,
No.
Tuberculosis.
sir,
What is the typical histological appearance of a tubercular lymph node?
sir, there will be central necrosis, central caseous necrosis.
You have to mention that. Until unless to mention the word caseation.
Yes, sir. Central caseous necrosis.
Typical, yes.
And
Langerhans type of giant cells, and in periphery there will be epithelioid granulomas.
Yes. So these three things are very important: epithelioid granuloma, caseation necrosis, and Langerhans type of giant cell. These three things define tuberculosis histopathological, right? These three things have to be mentioned, right?
Yes, sir.
Yes. What changes? I mean, now let me ask you a fundamental question.
Yes,
How
sir.
did the tubercle bacilli? I mean, how did the tubercle bacilli enter the lymph node?
Sir, if a patient is a case of pulmonary TB, it can go through the hematogenous spread also.
Your patient is not a case of pulmonary TB.
what
Sir,
is the route?
This patient,
Where from the tubercular bacilli travels to the cervical nodes?
sir, from the infection of the tonsils, it can go via lymphovascular lymphatic routes.
so it is an oral route, right?
Yes,
Through
sir.
the oral
Either from the pharynx or from the tonsil. These tubercular bacilli travel through the mucosa and then reach by lymphatics to these lymph nodes. This is the usual genesis of tubercular node.
Yes, sir.
What are the stages in tubercular node infection? There are defined stages for
Yes.
tubercular lymph nodes.
Sir, stage of lymphadenitis, that is the lymph nodes will enlarge. There will be discrete enlarged lymph nodes. stage of peritonitis, stage of abscess formation, stage of collar stud abscess, and stage of sinus formation.
Yes.
And your patient is in which stage?
Sir, my patient is stage of lymph node is just enlarged, stage of lymphadenitis.
Stage of inflammation, where
Yes, sir.
the inflammation is still limited to the lymph node.
Yes,
It
sir.
has not gone, it has not become a peritonitis, right?
Yes,
That is
sir.
when it becomes matted.
Matted. Yes, sir.
Okay, fine. Yes. So do you need to do any other investigation before you start antituberculous treatment?
Sir, I'll do the liver function test to check the.
Now, any other thing? Now people does not start treatment without this test. That can be done in your biospecimen even.
Sir, culture and sensitivity of the
Before that, what is that now called as?
CB-NAT.
Yeah. That gives you answer lead for rifampicin sensitivity.
Rifampicin sensitivity is present or not, sir? Yes, sir.
And of course, you have to exclude pulmonary tuberculosis. That is another thing. Right?
Yes, sir. Yes, sir.
That has to be excluded. Okay,
Yes, sir.
and you have to also make sure that whether the patient is diabetic or not. So you
Yes,
have to do certain investigations like blood sugar, urea creatinine to come to know about the renal status of the patient, isn't it?
Yes, sir.
Because you
Yes.
give drugs which are highly toxic.
Yes, sir.
These drugs are hepatotoxic.
And
Yes.
yes,
And
sir.
I mean, all these drugs, I mean, each one of them has very, very high toxicity levels in different organs, right?
Yes, sir.
Okay. So, though we don't start antituberculous drugs ourselves, because nowadays it is part of a program, national program. So it is
Yes.
usually referred to a community health
Correct.
center under the corporation or something. So what are the common drugs? Just if you can name them.
Sir, there is a first line of drugs are present, that is isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin. And we have
Streptomycin
got
is not first line drug. Streptomycin
no,
is,
sir, no,
it's
it's
a CAT2 treatment. It's a
yes, sir.
CAT2 treatment. In CAT1,
Category-
streptomycin is not included.
Yes, sir. And in category 2, we have got amikacin, and levofloxacin, moxifloxacin, and
There
there
are
are
a lot
new.
of other drugs. There are a lot of other drugs now being also in the national program.
Yes, sir. That is Bella Quid and Della Manit and Prema Manit.
So what do you think? This patient has got a full treatment of pulmonary tuberculosis. This patient now coming with granular tuberculosis. What should consider in the treatment protocol?
Sir,
Will you put on the same regime? Will you put on the same regime?
it might be a case of reactivation. So for before putting the patient on a regime, I'll do a rifampicin resistant and a sensitivity test for these drugs.
If you want to see complete treatment and within 4 months there is a recrudescence,
Yes, sir.
the
There
first
is
line drug may not be a complete treatment for this patient.
Yes, sir.
And this patient will require a longer period of treatment.
Yes, sir. Yes, sir.
Sure.
Now, apart from tuberculosis, now if we can shift to some other disease in the neck, because neck, as you know, I mean, how many lymph nodes do you have in the neck? Any idea?
Sir, six group of six stations. That is level 1, 2, 3, 4, 5, 6.
Seven.
7. Yes.
Isn't it? 1 to 7.
Although it's
What are the
anti-mediastinum,
number of-
but still is in the part of cervical lymph node. Level 7 is in the thorax, in the anti-mediastinum, but it's also included in the extended cervical lymph node.
Yes.
Another simple question, as Makhanda said, that you see, we have levels 1 to 7. But remember, the level 1 to 6 is only palpable. The 7 is not palpable.
Yeah.
Right? Okay,
Yes.
fine.
How do you assess? How do you assess level 7 node involvement or not?
Sir, we have to do a Pemberton test.
Pemberton test. No. The Pemberton will give you the idea. This is the imaging. Very
Yes,
clear.
sir. Yes,
The
sir.
bone in front, you cannot palpate the you have to do
Yes, sir.
imaging,
Yes, sir.
particularly CT.
Yes, sir. CT chest. Yes.
Now, apart from these 7 levels, are there any other lymph nodes in the neck which have not been brought into these levels? I suppose you get my question.
Yes, sir. There are posterior occipital nodes also presents. Retro.
Exactly. Yes, that's what I'm looking for. There are,
Preauricular, post-auricular.
Yes, sir. Preocular, postocular. These are also present, sir.
there are parotid, pre-parotid, intraparotid, right?
Yes, sir.
Occipital group. So many other groups are still there, which we have not included within these lymph nodes, within these 7 levels.
Yes, sir.
Another basic question. Now,
Yes, sir.
why did we stop at 7? We could have made it level 8 also. We could have gone beyond that, isn't it? I mean, it's a very simple, fundamental question. You start from level 1, you suddenly stop at level 7. Why not level 8, level 9, level 10? Have you ever thought about it?
So these are not easy to palpate.
Even 7 is not palpable. I told you earlier. Level 6 only are palpable with the clinician's fingers.
Yes, sir.
Level 7 is not palpable, right?
Yes, sir.
The reason is simple. I'll tell you.
Yes, sir.
Because if it goes beyond level 7, that is, if it goes in the mediastinal group, that is in the hilar group or below the innominate artery, those lymph nodes are considered as M1.
Yes, sir.
You get my point?
Yes,
So
sir.
those are not considered regional lymph nodes,
Yes, sir.
right? So that is why we have not gone beyond level 7.
Another question, Behrul. What is
Yes,
the
sir.
boundary of level 6 nodes? Which area you said is level 6 nodes? Above, below, on either side?
Sir, above it is the inferior border of hyoid bone. Below is the suprasternal notch, and
Yes.
laterally it is the medial border of sternocleidomastoid muscle.
Yes. Because deep to sternocleidomastoid will be your level 2, 3, 4 nodes.
Yes, sir.
What is the area of level 2 nodes to go clear landmark?
It will be below the angle of mandible to above the hyoid bone, along the upper jugular vein.
Okay.
What is the superior extent? Superior extent?
Below the angle.
Upper level.
No,
Below the
angular mandible is a submandibular triangle area, but this upper is up to the base of the skull, where the jugular vein exits from the base of the skull. Okay, that is the limit of. It's a base of the skull to the hyoid. And
Yes.
if you go by internal jugular vein, it's a upper third, mid third, and lower third.
Lower third.
So mid
Yes.
third boundary, if you take a bony boundary of the mid third, where do
From
you end?
below the hyoid bone to the cricothyroid to the cricothyroid membrane
Cricoid cartilage or cricothyroid membrane.
in middle third of interjugular vein.
Yeah. And the below is the level 4. Good. You have
Yes.
read it.
Yes, he has gone.
I think we can conclude.
Okay.
Okay. Thank you. You answered well. But always keep in mind that anatomy will be asked. You see, it's a very nominal case of tubercular lymphadenitis. Might go to malignancy with a DD of any of these, and then anatomy is important.
Yes, sir. Yes, sir.
Okay. Thank you, Dr. Shah.
Thank
Yeah.
you, sir.
Yes, thank you. One more thing, that because tubercular lymph nodes we normally don't give in short cases these days, because it is very unusual for a tuberculous lymph node to be admitted to the surgery ward. And do remember that when you come up with neck nodes in a short case. Okay, thank you.
Thank you,
Thank you.
sir. Thank you.